I think I'm on.
Okay, so if you don't mind muting yourself, that'd be great. So I'd like to welcome everyone to our FANA speaker series this September with Dr. Linda Herbert. I will share my screen to introduce Dr. Herbert, and then I'll give you the reins. Oh. Is everyone able to see the screen? All right. So today's session is called Beyond the Bite, Navigating the Emotional and Behavioral Aspects of Food Allergy Treatment. This activity is approved for 1.0 contact hours of continuing education by the American Association of Nurse Practitioners. And this activity was planned in accordance with AANP accreditation standards and policies. So I just want to quickly introduce Dr. Herbert, who is the Associate Professor of Psychology and Behavioral Health at Children's National Hospital in Washington, D.C. Dr. Herbert is the Director of Psychology, Research and Clinical Services for the Division of Allergy and Immunology at Children's National, a program which she started in 2013. Dr. Herbert is an NIH-funded clinical researcher whose research interests include pediatric allergic diseases and the development of behavioral interventions for patients with food allergy and their caregivers. Currently, Dr. Herbert is the principal investigator for NIAID-funded clinical trial of behavioral intervention for early adolescents with food allergy to support their growing food allergy autonomy. She's also a co-investigator on a multi-site prospective longitudinal cohort to systematically investigate disparities among Black, Hispanic, and white children in food allergy clinical and psychosocial outcomes, food allergy phenotypes and endotypes, and food allergy management practices. Dr. Herbert presents her research at pediatric psychology and allergy and immunology conferences, and she is a prior recipient of the Heritage Lectureship Award by the American Academy of Allergy, Asthma, and Immunology. She regularly engages in advocacy work with national food allergy organizations. So welcome, Dr. Herbert, and I will pass the screen control to you.
Thank you so much. I'm really happy to be here with you all, and thank you, Olga, for inviting me. So I'm going to share my screen and then put this into presenter mode. Give me one moment to do that. Okay, so thank you so much for that introduction. I am really, I really identify as a clinician and a researcher, but we're diving really into the clinical side of things today, which I love talking about. I just as a little bit of like extra background, I am routinely in our oral food challenge clinic with families. I've attended over 2,000 food challenges now. I had to do a calculation recently, and I've seen many of these, and am now helping families as well with Xolair injections and Xolair assisted food challenges. So I'm excited to talk to you about navigating this emotional and behavioral impact of food allergies and then food allergy treatment. So my disclosures are that I have funding from NIH and from Leidos, and I've received speaker fees from several food allergy nonprofits. The objectives of our talk tonight are to describe first kind of the landscape, the psychosocial impact of food allergy on patients and their caregivers. And then the latter part of this is to identify psychosocial considerations of novel food allergy treatments, and then to go over some strategies that healthcare professionals like yourself can utilize to promote patient coping during these types of food allergy treatment procedures. And I know we'll have time for questions at the end, but you're also welcome to interrupt me. I'm not going to monitor the chat, but Olga, if you want to, and I mean, just feel free to jump in. I love making this conversational if that's something that is nice for you all as well. All right, so first we're going to characterize the psychosocial impact of food allergy on parents, patients, and caregivers. So as you know, there's many different types of food allergies, and really, like, we have families that are entering the world of food allergy typically when their kids are really young, and their first allergic reaction can be one laden with a lot of emotion, and some families even tell us about feelings of traumatic experiences. And there's a lot of reasons for this. Like one of them is that with kids being so young, when they frequently have their first reaction, it's already a stressful time. You're parenting a young child, you're introducing new foods, and many families don't have a background in allergies, so they don't naturally have medications on hand that they might need, or even necessarily know what's happening if their child starts to get hives or is red or is having difficulty breathing. And so as an allergic reaction progresses and a family might need to go get emergency care, there's a lot around that, a lot of emotion, a lot of feelings of, could I have done something different? What is happening here? Is my child going to be okay or not? And families then also can experience stress subsequently during the diagnostic process because there's a lot of information that you have to take in. As you guys know, you have to learn how to avoid food allergens, not only just by reading food labels, but feeling comfortable advocating and communicating and asking people in a lot of different social situations whether or not foods are safe. And you also have to suddenly be ready to identify allergic reactions when they occur, and then also feel that you know what to do and that you can handle doing what you need to do in that moment when you make those decisions. And again, many families don't have medical backgrounds. Using a needle on their child can be very anxiety provoking. Deciding when to use emergency treatment, just that word emergency treatment, can be very scary for families too. And then thinking about how they have to then also communicate and teach others how to keep their child safe. All of that can be a lot. On top of this, the things that are required of food allergy management, avoiding allergens, can really require changes to family dynamics as well. So some families, they're not ones that cook a lot, but now suddenly they have to learn how to do that, or they were, have very busy schedules and it's very hard for them to make meals and prepare things at home. There's just a lot that might have to change. And you layer all of that with the unfolding nature of diagnosis, where you might get diagnosed with one food and then another and then another. And this whole landscape can take a while and can be feeling really big for families. So there's a lot of stress and anxiety and worry that can come up in this early diagnostic period. Then we have families reach what some might describe a new normal or more stable disease management period. And this is when families feel like they have a routine, they know what to do, they have their people, their places, their things that they trust, that they feel comfortable with, and they might feel in a better place. But kids are constantly growing. There's new things that kids are learning to do. There's new schools, there's new friends. Kids' brains are changing, so they understand things differently. So there's this kind of cycle and kind of set of changes and life transitions that happen. And when they do, they bring up new challenges and new times of adjustment. So as kids understand more about their allergies, they might have anxiety and questions. As they make new friends, there's new people to teach. As kids hit adolescence, they're having to be ready to do things on their own. So there's a lot that goes into that. And then we layer that with, possible allergic reactions experiences, which can spike anxiety, the possibility of new allergies, new information, that can cause a readjustment. And as we'll get into a lot later, all these new treatments, these new opportunities that families are having to decide among. So the landscape of this is that there's a really stressful period at the beginning when you're learning everything, but there's these other waves that happen where families might feel stressed and anxious and upset. And we all know food allergy management takes place in so many contexts. So it's in the home, it's in school or daycare, you're navigating it in the context of social events, parties, activities, things that like as a family are important. Then you're also navigating it in the context of extended family, potentially babysitters, and thinking about travel. So food allergy management really spans all these different aspects of daily life. The literature on the impact of food allergy has been growing in the last, I'd say, 25 years. In the beginning, we understood a little bit about like the quality of life aspects of peanut allergy, and some of that initial work was done by Scott Sacher and his colleagues up at Mount Sinai. But since then, we have had a growing amount of interest and a growing body of evidence that children who have food allergy and their parents report increased stress and daily burden and increased anxiety, which we'll get into a little more. And with that comes a decreased quality of life, especially related to diet range, which I think we sometimes overlook as being a joyful part of life, like having a lot of foods you can eat, a lot of cuisines, things that you get to, flavor your life with, but then also social limitations. And one of the things that I really, talk a lot about with families here is that feeling stressed, feeling that food allergy is burdensome, that is very normal. That is just a part of having a chronic illness. It doesn't mean there's something wrong with them. It doesn't mean that it's a clinical level of anxiety all the time, but it's a normal expected thing. And so we educate families about like what they might expect and how they might feel. So a lot of emotions are really common, and we try to validate these and help families process that. Have included this slide. This is a graphical abstract from a paper that I was recently on with some colleagues in the UK and Canada and the US and throughout other parts of Europe. And the reason that I include this slide is to show you that having stress related to food allergy is not just a US concern. This is something that we are seeing globally. So in a study of well over 1,000 adults with food allergy and almost 2,000 caregivers of food allergy from over 20 countries, we found that 67% of adults with food allergy and 77% of caregivers reported experiencing some type of food allergy related psychological distress. So this is something that's not unique to the US, but certainly there's variability, across these different countries and like what kinds of policies there are that might support or kind of impede someone's adjustment to food allergy. If we delve into stress and anxiety, I'm going to show you a couple different pieces that I think about and that come up a lot with families. So, of course, one of the huge ones is allergic reactions. So families worry a lot about the potential for allergen exposure, as well then, of course, with what would happen in the event that their child is exposed to their allergen. And some of the things that I mentioned before about what they have to learn, that's what is happening here. They're worried about, will my child be exposed? Will I know what the symptoms are? Will the symptoms be very severe? Will I know what to do? If I'm not there, will someone else know what to do? Will my child know what to do? And sometimes our families even, take it to a catastrophe, and they think about, possibility of fatal food-induced anaphylaxis. So worry about allergic reactions is certainly at the forefront of a lot of stress and anxiety that we hear about. We also are starting to understand a lot more now too about food allergy related social anxiety as well. And this is something that we don't necessarily always ask about in clinic, but certainly can come up if you start kind of asking more about how families make decisions about where they go, where they eat, who they're spending time with. And what comes up here for families is anxiety about, asking, advocating, like, how will I be perceived? Will I look different? Will someone view me as that mom? Will I be stigmatized? And so that can lead families to be avoidant of situations that perhaps they would have a lot of fun at or like would be safe at, or to go to situations but then not advocate for themselves, potentially putting them at risk. We also see stress and anxiety, of course, about introducing new foods. And so this can relate to really young kids. So parents who are concerned about, a second child and how they're introducing new foods for that baby, or how they're introducing additional foods to the child with food allergy if they're young and have had their first reaction. We also can think about this anxiety about food introduction after a food challenge as well. Like, how are we going to feel more comfortable eating this? Then, of course, there's very natural stress and anxiety about medical procedures, skin prick tests, blood draws, oral food challenges, injections, all of these things, which, we see across the board with young kids and even with older kids. We also hear about stress and anxiety about other caregivers. So a lot of times our families, especially moms, will tell us that they feel somewhat isolated. They might feel that all the responsibility is on them. And a lot of that is because they know so much about their child's food allergy, and it can feel hard to trust other people, to feel like you can believe that they'll take care of the situation when you need them to, and that you are communicating with them well enough that they understand what they need to do. We also hear a lot of stress and anxiety about future food allergy management. So sometimes in clinic, I'll have, a parent of like a 3-year-old, and they're already asking me like, what's going to happen in college? What's going to happen when they're an adolescent? What's going to happen when they have a job or roommates? And so there's a lot of this worry about, is this ever going to go away? And if it doesn't, what is my child's life going to look like? And will they be able to navigate all of this? And now we have stress and anxiety that comes up around medical decisions. So having a choice, which is a beautiful thing in food allergy to have treatment choices now, but that necessarily can bring up some decisional uncertainty, feelings of guilt, feelings of anxiety, even when you do make a decision, wondering like, did I do the right thing? And this is something that we are actively navigating now that we have OIT and Xolair. So clinically, what I'm seeing and what you might be seeing in clinic are a few different ways that stress and anxiety present. So I think about anxiety as presenting in 3 different ways. There's behavior, and there are cognitions, and then there's also physiological symptoms. So thinking first about the physiological symptoms, we might see that there's like a hypervigilance to physical symptoms. So in the child, that might be kind of wondering if like a feeling in their chest, in their throat, or in their mouth is a sign of an allergic reaction, or if it's something else. And with our kids that have asthma too, like this can be really challenging because they're trying to differentiate asthma from allergy from anxiety. We might also see that there are parents who are then also very hypervigilant to what their kid looks like and how their breathing sounds. In both kids and parents, we might see reports of body tension, or actually see like really rapid heart rates or shakiness, things like that. We also then will notice cognitive sides of this too, and that's where the worry comes in. So worry about allergen exposure, worry about that social scrutiny that I was mentioning. And so these are the types of things that can keep people up at night, right? Like you have like your very tired parents who are saying, I couldn't sleep because I was thinking about, what's going to happen when we go see grandma next week. And we know that this certain family member is going to be there and they're not, very open or receptive or understanding of allergy. Like, what are we going to do? How are we going to make that decision? Or, worried about travel. Like we're going to be traveling to this place I haven't been before. What are we going to do? How are we going to navigate that? So kind of this rumination about things and a difficulty sleeping, paying attention, things like that. With some of my kids that I see for therapy, that worry can interfere with school and with social interactions. In particular, if there's like a party at school one day, I've had kids that have a hard time paying attention leading up to that in school because they are focused on like, am I going to be touched by an allergen? Is it going to be on the same table? Like, will it be near my plate? Things like that. And so then I probably should have put these on the flip side because I was starting with physiological and cognitive, but we then might see behaviors that are happening as a result of some of the physiological and cognitive piece or just on their own. And so one of the big ones is social activity avoidance. So hearing families say, we're just not going to do that. We don't feel comfortable. We feel really anxious. We just don't want to go to XYZ restaurant. We don't want to go to XYZ vacation with our parents, things like that. And this is, that's really sad. Like we want families to feel like they're able to engage in these activities and feel confident, and, feel good about like derive meaning from a lot of these activities in their life. We might also see food avoidance. Now, and of course you're thinking, well, yes, they need to avoid their allergens, but we'll sometimes see like an over generalization to foods that are safe that might seem similar to the target allergen. So an example that comes to mind clinically for me is like I've had kids who have wheat allergies who then avoid a lot of breads and crackers and cookies and things because of that similarity with foods that actually have wheat. So there may be foods that they could be eating, and enjoying like a much broader diet that simply they're not engaging in. We might also see frequent checking. So kids who will ask 5, 6, 7, 8 times, like, are you sure this is safe? Are you sure this is safe? Or themselves are noticing that they're checking the label over and over, or that a parent is doing that. That is something that comes up a lot in therapy as well. And then related to the worry about social scrutiny is the behavior of not disclosing. And so that could be not disclosing to a person that's serving you food or a person who you're getting to know. Like, we certainly want to give kids the ability to decide in some situations if someone needs to know about their allergy. But there are important people that need to know, such as the server at the restaurant or your teacher or your coach. And so what you might see from some of this anxiety is a decision not to disclose or not engage in a safety behavior because of that worry about what will they think, what will happen. I also want to bring up a little bit about bullying for you all as well, because this certainly happens in the context of food allergy too. So just as a bit of an overview, I've done some work where we look to see how many kids are bullied and what, like, who's telling us like that this is happening. So in one of my studies, we ask families a yes or no question, like, has your child ever been bullied for food allergy? Have you ever been bullied for food allergy? And then we also gave them like a list of behaviors that they could tell us they had experienced. And what we found is that kids and parents didn't always agree. Parents many times were unaware of the bullying that was happening. And when we just asked kids this yes, no question, half of them who told us on the inventory that they'd been bullied were not reporting that they were being bullied. And so the things that we're seeing here, they're things that really are alarming. Like, they affect self-esteem, but also can simply be dangerous. Things like having belongings damaged, having an allergen put in your food, being threatened by it. This is something I've been helping families navigate with 504 plans and other school plans. So what I really encourage providers to do, and this can be any healthcare provider working in allergy, is to ask kids, like, what are your peer experiences like? Are there people that support you in your food allergy management? Are there people that make it harder for you, that kind of actually harm you or like threaten to harm you? And we just want to really be identifying this so that we can support kids, especially in that school setting, so that they feel safe, that they feel included, and that it can bolster their self-esteem. We want them to not be worried when they're in the school context about what will happen to them at lunch or at parties or things like that. So that's kind of like our base, our background for like what food allergy is like in general. And now, we're going to transition to talking about some novel food allergy treatments. And this is such an exciting time. Like, I really do love the fact that we have choices for our families. They've been asking for this. They've been advocating for choices. And so we now have the opportunity to give them to them and help them make these decisions and partner with them as they go through these treatments. So the thing is, anything that's good also has challenges. So we want to be mindful of them. So first, we'll turn to Xolair injections. I'll warn you, the graphic I'm about to show you is very busy, but I don't see a way around it. So this is a graphic that I created for a grant application, and I'm thinking of translating this into some educational handouts for families. But Xolair is exciting, but there are so many decision points for it. And there's a lot for families to wrap their head around. And in the field of allergy, like allergists, the healthcare provider, like everybody's still figuring this out at the same time too. Like, what are all our steps going to be? So, so the way that things are kind of working right now, at least according to my understanding in our clinic, is that we have kids on at least 16 weeks of biweekly or monthly Xolair injections with continued allergen avoidance, where they get their first 3 injections in the clinic, but they can get more in the clinic if they want. And then subsequent injections can be at home, and this is determined by their IgE level and weight. And then in our clinic, we're doing things like 6 to 12 months later, but kids can then have an oral food challenge. And you all know this is a 4-hour procedure where they're at the hospital. And we can do this because Xolair is for multi-food allergy treatment. This could be for many foods. This could be 1 food, it could be 6 foods. So this could be happening over the course of several months. If families choose to do an OFC, then we see what happens, right? So if that child demonstrates tolerance of the threshold allergen amount to at least 1 allergen, then there's additional decisions. Do they continue Xolair and introduce the allergen into the diet, Do they continue Xolair, start OIT for one of the allergens? Do they continue Xolair and just continue with allergen avoidance? Do they stop Xolair and continue allergen avoidance? And then you have the same types of questions that come up if they don't demonstrate tolerance. So there's a lot of choices there as well. Or families might choose never to do a food challenge. So one of the challenges for us as providers here and for families is to help them navigate like this complicated set of decisions. And what the reason I put this busy slide here is just so that we know about that, right? Like, and it's not just one decision point. It's not, do we do Xolair or not? It's, okay, we're going to do Xolair, and then what do we do? And then what do we do? And I'm sure I could make many more arrows that come off of here with more food challenges and lots of different things. So this is the landscape that we're in. If we boil it down to like additional logistical components, we know that Xolair treatment feels a little different than an intramuscular injection like epinephrine. And kids are already very nervous about epinephrine. That's a whole other talk, but we know that Xolair is a little different. It is objectively more painful than IM injections. This is something that we hear consistently from our kids, similar to what they say about Dupixent. And we know that there's a higher volume that happens with each injection, so it isn't necessarily just an in and out. The procedure itself can take longer, in part because there are multiple injections that are happening in one sitting. And so this is just a bigger thing than using an EpiPen, of course. And so the challenges that can come up with all of this are parent and child anxiety and child refusal. And so there are things though that we can do to help families if we kind of acknowledge this from the outset and be planful about it. So what I wanted to do next is talk a little bit about like anxiety in the context of procedures and what it is that folks can do in the moment and also prepare for in the moment when the procedures happen. Okay, so let's think a little bit about what increases anxiety. And I think it's really important to know that like all of us have a role in helping manage anxiety. There are things that all of us can do. It doesn't have to be a mental health professional, that all of us can do to help kids and parents cope with these procedures. So the first thing is timing. A lot of times what kids will try to do to get out of something that they're scared of is to stall. So of course they want to avoid a feared situation, and stalling and allowing like this avoidance to continue increases anxiety. So you might be able to imagine a kid in clinic who comes in and they're like, just keep waiting, not yet, not yet. I'll let you know when I'm ready. I'll let you know when I'm ready. And their distress just kind of keeps amping up. Another thing that can increase anxiety is the way that we talk about the procedure and the knowledge that the child has about the procedure. So if they don't know anything about what's going to happen, that certainly can increase anxiety quite a bit. But additionally, if they only hear some really vague information, or if they only hear things that are really hard for them to understand, that can also increase anxiety. So this is where like we pay attention to child development. So we don't want to explain something to a kid who is 5 years old the same way that we would explain something to a 15-year-old. Also, like hearing only like hushed whispers about what's going to happen, or like, oh, like this shot's going to happen. And it's a lot for kids to not know about what will happen. The other thing that can increase anxiety is observation of others' behavior around you. Kids are so observant, and we know that modeling behavior to them will tell them how to respond to something. It tells them what to do. So when we see other people around us who are anxious or upset, that communicates to us that we also should be anxious or upset. So when you have a parent who comes in and they're doing this, getting ready for the Xolair injections, and they're anxious and amped up, that's telling the kid that they need to be anxious. Similarly, as healthcare providers, like if we go in the room and we seem a little like anxious about like, oh, I don't know like how this kid's going to do. I don't know how it's going to go. Like that's being communicated to the child, even if we're not saying that. So our behavior can increase anxiety. The other thing that can increase anxiety is criticizing, which, we hope that parents aren't doing, but, if kids are hearing parents saying, like, you're not doing it right, you're not sitting still enough, like those things increase anxiety. But what's counterintuitive is that apologizing and providing too much reassurance can also increase anxiety. So, I'm so sorry that you have to do this. It's going to be okay. It's going to be okay. It's going to be okay. It's a natural instinct that we might have to say things like that. But we absolutely know that these are the things that can increase anxiety. And it's a little sidebar. Years ago, when I was an undergraduate, I worked in a pediatric research lab where we watched and then coded videos of medical procedures for this type of behavior. And so I've watched many procedures and really have seen how like this apologizing and reassurance can actually lead to child anxiety. Another thing is when adults give a lot of control to kids. Obviously, we want to think about like potential for choices and what are reasonable choices, but telling the child, like, where do you want to do this? What leg do you want to do? How do you want to do this? Are you going to count to three? Like, there can be way too much for the kid, and that can actually then help them stall and avoid, which then increases anxiety. In contrast, what reduces anxiety is giving kids really clear and detailed and age-appropriate information about how procedures feel and about what will happen. And again, that age-appropriate piece of it is really important. So we're explaining things differently to a 5-year-old than we are to a 15-year-old. 15-year-old might have a lot of questions and we can tell them a lot. A 5-year-old might have questions too, but just of a different type. So we give this concrete information about how things will feel and what will happen. And I'll give you some examples of that in a bit. Then, of course, the flip side of our behavior being able to increase anxiety, our behavior can also reduce anxiety. So a big thing that I do in clinic and that you all can do is encouraging the use of coping skills. So, okay, like, we're going to use your relaxation skills. Let's take some nice deep breaths. Let's do some pedal breathing where we like breathe in and out like a flower. Let's use box breathing. Things like that. You can also encourage the use of verbal and visual and activity distraction. These would be, verbal distraction would be you just asking them about completely off-topic things that aren't related to Xolair. So, tell me how school's going. Tell me about this recent trip you did. What's something you're really looking forward to next week? Things that are very different than the procedure itself. Visual distraction might be, having them point out to you something that is on a picture on the wall, asking them questions about that, or just simply holding something away from them that they can look in like a different area. An activity distraction would be when you're kind of combining all these things together, where you're actually engaged in something that uses visual, verbals, and all of that. We also can encourage a coping skill that's called positive self-talk. So, kind of hyping them up, like, you can do this. You've had a shot before. I know you can do this. You're doing a great job using your coping skills. You are a brave child. This is all, all these things you kind of come up with them together about what they can say to themselves. Another thing that reduces anxiety is giving limited age-appropriate choices. So it's not appropriate for the kid to choose, how long do they wait necessarily before they even start the procedure, but you can give them a choice like which of your two legs. And we would call that a forced choice because ultimately they have to do the procedure, but they can choose an aspect of the procedure. Or you could have a choice like, do you want to sit on mom's lap or sit on the chair? And then we use a lot of positive reinforcement. So praise simply for coming into clinic. I'm so proud of you that you came in and you got your vitals done. Like, that's wonderful. Just giving them this reinforcement for every step of the way. Reinforcement, praise, and rewards for practicing coping skills in advance as well. So here's some examples of language that you can use. So for sensory or procedural information, you can tell them really specific things like, first, I'm going to clean your arm, or you're going to feel a cold alcohol pad, and then I'm going to use freezy spray or something like that. Or you can do things like saying, this procedure is going to be shorter than an episode of Bluey. Something that like kind of targets for them so they can understand like what this really means. The limited choice example, again, is like, where do you want to get the injection? Do you want to get it on your left leg or your right leg today? Distraction, let's get your mind off of it. Tell me about that movie. Just asking them about things that really are very different. Or you can prompt them with activities as well. Like when I count to 3, I want you to blow the feeling away from your body. And then lots of praise. That was hard. I'm really proud of you. You were able to get through that procedure. Good work. You did a great job with your deep breathing. You did a great job holding still. The language to avoid, you might be guessing at this point, are things that are more vague and sensory. So things like, this isn't going to hurt, this won't hurt, or saying the opposite, like this is going to hurt. It'll feel like a bee sting. Like these things are kind of non-specific for kids. Telling them, you tell me when you're ready, like that is just way too much control for them. The reassurance and apologizing piece, you're going to be okay. There's nothing to worry about. This, I'm so, so sorry. And then also things like a negative focus language, like saying, don't cry, or in an angrier way, don't cry, or you need to hold still next time, like you weren't still enough for the procedure, it didn't go well, all those types of things. And then we also want to think about rewarding kids for their positive behaviors. And when we think about establishing what's an appropriate reward, I would be thinking about like setting really clear and specific and consistent expectations. And rewards should be very tangible and delivered like subsequently, like really quickly after something. So for some kids, this might be saying like, I want you to sit down on your mom's lap. Okay, you get a sticker for doing that. Like, I want you to take your pants off so I can get access to your leg. Great, you did that. I will give you another sticker for that. And they can have kind of like a sticker chart that they work through. And then after they get the injection, having something that may be a prize closet, like something they can immediately reward themselves with. So some of the things that we do in clinic as we kind of think about all the things that I just talked about is we really try to make a plan with the parent in advance for some of this. Sometimes, of course, you don't quite know. And so like you go through one of these injection procedures, like what you might need to do next time. But since we do a couple of these, like it's helpful, you do have time to make a plan with the parent. So it can be helpful to meet individually with the parent. So without the child, where you can talk really freely about how they think their child might do and like answer any questions that they have as well. And then what I recommend doing is reviewing strategies for decreasing their anxiety and for improving behavior management. So kind of coming up then with this game plan. So you can talk through with them like, okay, here are our options. We can encourage relaxation. We can give a lot of praise. We can get like a sticker chart out. We have a prize closet. We're going to limit choices, like really just kind of get through all of that together as a healthcare team with the parent and then try it. You can practice some of these strategies in advance, and then you can implement them. So I wanted to share with you a case example for a patient that I've been working with for a little while. So this is a patient who experienced increasing distress during Xolair injections. So this patient, for the first Xolair injection, like had no anxiety, didn't know what was going to happen really, and so went into it like, okay, this is going to be fine, and then was very distressed afterwards and thought it was painful. And then with each additional Xolair injection, got more and more distressed, and the parents felt like we want to keep coming into clinic. So this is actually a parent, a kid that I've been seeing in clinic monthly for their Xolair injections. So my psychology team was brought in at the 4th injection because it had gotten to the point that they didn't really know what to do, that, this child was just so distressed, couldn't even get them to sit on the parent's lap. And it was just really hard for everybody. So, so after kind of bringing psychology in and having us see what was going on, we ended up making a game plan for this family. One of the things that we first did was try to use really developmentally appropriate language about Xolair. So we were explaining, like this makes your body stronger. This helps you not get sick after you eat nuts. This keeps you safe, things like that. And then we also gave them some medical equipment and trainers to take home, and kind of built this like little medical kit for their child to use. And in subsequent injections, they would bring it back along with one of their stuffed animals, this cute little elephant, and they would have been practicing that. And the child is getting exposed to these things outside of just the shot situation. And then we also plan for behavioral reinforcers for subsequent injections as well. So we plan to like play a game afterwards, and the parent talked about like a snack that they could bring that the child, usually doesn't have access to, like a really special treat that would happen at the end. And so during subsequent injections, we would start by kind of having this like a prep discussion with the nursing team and the family. We would talk about the plan, like, okay, here's what we're going to do. Here's how this is going to go. Everybody's on board. Let's go with it. We use pain minimizing strategies like freezy spray. This child really loved the Buzzy Bee. We used ice packs as well as a comfort hold, like the straddle hug position. And then this child was getting 2 injections, one of which was like a longer injection, took like a couple seconds, and then the last one took just like 1 second. So we would take a break in between these injections, and we had like a shake it out procedure where you'd get up and kind of jump around. We also used forced choice, where we asked like, which leg do you want to do? Well, how many numbers do you want us to count to? What should we yell together? This kid loved dinosaurs, so we ended up all like, every time we shout like a T-Rex, and he loves that. We also, use verbal distraction the entire time that everything was getting ready, just talking about life and school. And then afterwards had this behavioral reinforcement of this special snack and then a prize. And after the injections, then we would debrief and think about like how it went, and think about like, was there anything we would want to change? So in the beginning, when I was working with this family, there were 2 little tweaks that I talked about with them. After the first time, we talked a little bit about limiting choices that the patient had, because it was really clear that there were way too many choices, and that was allowing them to delay things and stall. And I talked a little bit with the parents about how, we don't expect that this child will never be distressed about this injection. The goal is to help them cope with it and get through it, and then return to their baseline happy self. So the parent loved that, and in the next injection adjusted some of the choice making opportunities, and that really helped. And then at that point, I talked with them about the language to use during injections. There was a lot of the reassurance going on. So I redirected them to use some more directive language and concrete information, and they implemented that in a subsequent injection. And we also would debrief with the nurse. So like, what went well, what could we do? And we documented all this because it was really helpful a month later to remind ourselves, like, what is it that we did that went well?
Can I ask a quick question?
Yeah, absolutely.
Can you give some examples of what the directive language and concrete information would be instead of it's okay or almost done or something like that?
Yep. Yeah. So that's some of the things like this. So like, first I'm going to clean your arm, then I'm going to use the freezy spray, then I'm going to do the first injection, which will take about 3 seconds, and then we're going to shake it all out, and then we're going to do the same thing again. We'll do the alcohol swab, the freezy spray, and then it'll take 1 second, and we're all going to scream like a T-Rex, and then we'll be done. So it's just like being really, really clear about that, all of that order of things. Yeah, does that help?
Yeah, I just find a lot of times the parents during the procedure, or and us, we will be like, it's okay, I'm almost done, I'm almost done, I'm almost done during the actual shot. Do you find that that is counterproductive? If
Yeah.
during the shot, it's not good either.
Yeah, I would really hesitate to use language like that. And the thing is, I know how hard that is not to do that. I'm also a mom. I have a child who, she does well with injections, but there's other medical procedures it's hard with. And your instinct is there to like, you see a distressed kid and you want to be like, it's okay. Like, I
Right.
care about you. So it takes practice. I find that if you are ready with other language to use and you start saying all of that, then there's less of a hole that you're trying to fill, where you then are saying, it's okay, it's okay, it's okay. So the more that you can like come in with like, these are some planned things I can tell them, the better it is. And it does take practice, and like I'm not perfect at it every time either. Like it depends on the kid. You kind of have to get into your rhythm with it. But yeah, but I would think about using these types of things here.
Thank you.
Mhm. Okay. So then let's think a little bit about OIT. You guys know about OIT, of course, but if we think about the logistics of it, what makes it hard is that foods are different, new smells, new shapes, new textures, new tastes. Kids might have been told the food is dangerous, that they have to avoid it, of course, and this can lead to anxiety and fear. And oh, sorry, I wrote can result in anxiety, fear twice, but yes, certainly all of this can lead to anxiety and fear. So one of the strategies that we use, and so I'm imagining like, this kid has not yet gotten to the OFC stage, but I'm extrapolating to what I do with some other kids in food challenges. We use what's called like the touch, smell, kiss, lick, bite technique, which has been adapted from feeding therapy. And the purpose of this strategy with these anxious kids is to help decrease their anxiety about the challenge and to improve their ability to tolerate new foods through behavioral management principles, one of which is desensitization. So it's a gradual form of exposure to something that they might be scared of, as well as positive reinforcement, which is when we're reinforcing a behavior that we want to occur by saying something, by giving something, adding something to the situation to increase the behavior. And then by also eventually fading the need for all these things to happen. So the child is able to do this on their own. And so in the context of OIT, there are strategies that you might need like this that you use in like the beginning with like the first or second dose. And then the goal is that hopefully over time, they're not overly dependent on being prompted all the time to do something. So this is exactly what it might sound like. It's just kind of an order of things from what might be kind of least anxiety provoking to the most. So with kids, I will prompt them, first let's just interact with the food. Let's touch the food. Let's hold it, hand it to somebody. From there, if they're successful with that, then they can smell it. They can hold it up on a plate. They can hold it with their hand. They can then kiss the food. So it touches the lips, but it doesn't go in their mouth. They could do like a lizard lick, so just like a tiny bit, and then eventually take really small bites of something. And when you're doing this, like you're really kind of reinforcing with verbal praise or with stickers or any type of activity afterwards. After they do this, you can place a Lego, take a turn on a board game, all kinds of things like this to get them feeling more comfortable. And the goal is that eventually after they've had a little bit of this exposure at a slower pace, that they feel comfortable with actually taking a bite. And so we don't have a lot of time for me to get into all the details of this, but some tips about this is that you can include like a preferred food. So, after you take a bite of the thing that you don't like, have the thing that you do like. That helps with the taste, but also is a little bit of a reward. They could have a game or a book or some kind of preferred activity. So I used to do this a lot in particular. I don't know why I don't do it as much anymore, but I used to do this a lot with like board games where it's like you take a turn, then I take a turn, but you only get to take a turn if you actually take the bite. You can also, read excerpts from a book. You can let them listen to a song for 2 minutes, things like that. With older kids, they might want to chart their own progress on sticker charts or special notebooks, but really we want to provide a lot of positive attention and praise for any attempt at like engaging with this OIT dose or this food challenge dose. And so, so with this kiddo, I'm kind of melding together now 2 patients. I recently had a patient do 2 food challenges after having been on Xolair for a year, and they were very nervous about doing this and weren't even sure like if they'd be able to. So we used this technique to help them feel more comfortable. So we made a game plan by talking about what language to use, like how to explain the purpose of the food challenge. We talked a lot with the healthcare team and the family about what the target dose was. And because with Xolair assisted food challenge, like there can be a lot of wiggle room as to what the dose is. We decided with this particular child that the target dose would be really small because we wanted them to have success and to feel good about what they were doing. And the family's like, it's okay with us if then they do OIT and it takes a little bit longer to get to that bigger maintenance dose because we want to focus on the success of just having them try it. And then this particular patient I'm thinking about, we certainly did this touch, smell, kiss, lick, bite technique for the first dose. And it took maybe 5 minutes to kind of proceed through those different steps. But then once the child got through that first dose, they had a bit more confidence and they did not necessarily have to do each of those steps with subsequent doses. And we gave lots of positive reinforcement. And this child that I'm thinking of, they tolerated the food at the end of the day. And then we talked about like what the plan would be for home introduction, thought about a schedule, a reward system for doing that too. So we're really in this like new era of food allergy treatment, which is really interesting, but just requires a little bit of problem solving from all of us and new skills. So I'll summarize because I do want to give a little bit of time for questions that, there are common psychosocial concerns pertaining to food allergy. And these new treatments are wonderful, but they're also bringing new challenges and stressors. But there are really effective behavioral strategies that any medical professional can use during injections, during OIT that can support patient coping. So I will end there and invite additional questions.
Thank you so much, Dr. Herbert. I will stop the recording and then we can maybe take a few minutes to do the Q&A. And you will also find in the chat a link to the evaluation survey for today's session to claim contact hours, as well as check out our monthly speaker series that are coming up in October, November, and December. In fact, in October, we have our own Ali DePelt with Dr. Amanda Cox coming and speak to us about food allergy prevention. So be sure to check out our website to register. And